Hi, I'm Matt Cortese. I'm an assistant professor of oncology at Roswell Park Cancer Center in Buffalo, New York. I specialize in treating B-cell lymphomas and CLL. So in our study with 14 medical centers throughout the country, we were looking at outcomes of patients with transformed follicular lymphoma with something called chimeric antigen receptor T-cell therapy, or CAR-T. And CAR-T is a way to treat cancers that have relapsed or have progressed despite conventional treatments, and uses our knowledge of the immune system to kill cancer directly. And this is a game-changing and revolutionary new treatment approach, relatively new. And we were really trying to identify which subgroups of patients with lymphoma will do better and who is not going to do so well. So we can design better treatments, give patients the information they need, hopefully in advance of going through treatments, and that helps them with treatment selection. Things like that are very, very important for us. So we looked at transformed follicular lymphoma, which is essentially a aggressive change of a low-grade lymphoma like follicular lymphoma. Follicular lymphoma is the most common indolent or slow-growing lymphoma, and despite that fact, that it grows slowly and typically doesn't cause problems for years. We can safely watch folks for a long time. Unfortunately, though, it can change, right? It can turn into a high-grade B-cell lymphoma, similar to diffuse large B-cell lymphoma. And this happens randomly, as far as we understand now, where patients may feel well and these aggressive lymphomas can emerge and cause problems. We have to treat them urgently and immediately, just like we would with a more aggressive lymphoma like large cell. Transformed follicular lymphoma is highly treatable, and the aggressive component is usually curable. CAR T-cell therapy can cure folks who have relapsed despite multiple other treatments, and very, very effectively, we've shown. So it was a multicenter retrospective study, meaning we look back in time and we see how people did, after the fact. And what we did was we looked at patients who have transformed follicular lymphoma and compared them with regular diffuse large B-cell lymphoma. And we looked and saw how did people do with CAR T-cell therapy and how long did they live. And we did, I think, a very robust analysis looking at survival outcomes, and we've shown a massive benefit of CAR T-cell therapy over de novo large cell lymphoma with CAR T. Very statistically significant results. And this is actually a new finding for the field, because we've known for a little while that transformed lymphomas do better with CAR T-cell therapy. And our work with others around the country at this meeting have shown that the transformed follicular lymphoma component is actually responsible for the majority of that difference, and substantially better outcomes. And we're going to have to look and see why that is. And we've got some ideas on that, of course. So we know that outcomes with CAR T-cell therapy are improved if patients have little disease detectable at diagnosis. There's less toxicity, better efficacy. So when I talk about toxicity with CAR T-cell therapy, we're talking about inflammatory reactions, infection risk, prolonged low cell counts after the fact. So those are all certainly risks for everyone going through CAR T-cell therapy, but they're less if you're less inflamed and you have less disease. And that's been shown with multiple studies around the country. And our study showed similar findings as well. So CRS, or cytokine release syndrome, is an inflammatory reaction. Personally, I think it's a good thing to a low degree. Low-grade CRS is characterized by a fever. Usually, we treat with Tylenol and close monitoring, usually in an inpatient setting. There's outpatient CAR T-cell therapy now, which is a wonderful thing for patients. But if people get a fever at home, we ask them to come in, because what can follow is low blood pressure, shortness of breath, or ICANS, which is a neurotoxicity syndrome, which is associated with cellular therapies and bispecific therapies, where basically patients become confused, tired, highly treatable with steroids and other medications like anakinra. And we get patients through those kinds of things really, really well. But it can be scary, certainly, as people are going through it. So there are lots of factors that impact survival outcomes with CAR T-cell therapy. And the most important one for me is, can you survive treatment, right? So how well are you able to get around the house, do your daily living? Are you physically strong enough, right, to handle treatment? That's with any treatment. So good physical fitness, good nutrition, gentle exercise, pay attention to your body. If something's wrong, see your doctor, ask questions, stay informed. Very, very important things to do. The other things that we looked at medically are how did you respond to the last treatment? So if you'd never gotten to a remission with, say, multiple lines of therapy, that tells you that your cancer is more aggressive, more resistant, and that can include to CAR T-cell therapy, but certainly CAR T can potentially cure many patients who have these intrinsic resistance mechanisms baked in, but not everyone. But just know that that can influence outcomes as well. Always stay posted, clinicaltrials.gov. You can search like you're shopping on Amazon and look through available trials around the country. We've got many new CAR T trials out there. So even if patients relapse after CAR, we have bispecific antibodies approved. We have small molecules approved. And then second and even third CAR T-cell therapies are also are coming or and active in trials, including at Roswell Park. So many good options out there. This should give some reassurance to anyone with transformed follicular lymphoma that your clinical outcome, your ability to survive treatments and a long, healthy life, hopefully, is improved. Actually, you're relative to regular diffuse large B-cell lymphoma. We've shown that your outcome actually might be much better than has been told to you originally, which is a good sign. That said, if you had another transformed lymphoma, we have some other data coming out, hopefully at the tandem meetings in February, but we're showing basically similar results where other transformed lymphomas behave more like regular large cell lymphoma, and you may have less benefit, unfortunately, as opposed to the transformed follicular lymphoma. We're doing translational work now, and this is the most important thing in the future. Number one, to make CAR T-cell therapy safer, using small molecule inhibitors and other treatments to reduce the risk of toxicity, make T cells better. We had other work at this presentation looking at things like venetoclax for treating CLL, for example. It's another topic for another day, but essentially we've shown that that small molecule can improve immune function. And so this can be translated to patients with all kinds of other low-grade lymphomas or high-grade lymphomas for that matter, to make toxicity much less and hopefully obviously work much better so we get to a 100% cure rate over time. It's going to take years to get there, but we're going to get there in our lifetime, I think.